my YouTube channel phoenixphysio. Please subscribe. Hello physios, today's topic is a developmental dysplasia of hip. Okay, first we will start with the introduction. It was the conventionally known as a congenital dislocation of hip, also called as a CDH. Okay, now we will see the definition. This is the definition. It is the subluxation or dislocation or dysplasia leading to the minimal or no contact between the femoral head and acetabulum cavity. Okay, I am repeating again. It is the subluxation dislocation dysplasia leading to the minimal or no contact between the femoral head and acetabulum cavity. It may be due to the maldevelopment of the femoral head and acetabulum or both. Okay, here we can see this is the normal hip joint, here is a dysplasia into the hip joint, this is the subluxation, and this is the dislocation of hip joint. Okay, now we will see the cause. The causes are two type of causes, that is the skeletal cause and other cause. Okay, the first one is the shallowing of acetabulum. Here we can see the shallowing of acetabulum, the groove of concave surface, that is the decrease. Okay, the posterior displacement of the hip of the femur with a tendency for flattening. Okay, when the tendon is flattening, then that cause the displacement of the joint. Okay, in the neck of shaft of angle of femur or exercise atravessing of neck. Okay, they decrease the angle of hip joint. Okay, here we can see this is the femoral angle, and here this angle will be decreased. Okay, now other causes are genetic causes, hormonal therapy cause the joint laxity, and the mechanical theory faulty intertermination positions. Okay, these are the causes. Now we will talk about the risk factor. What are the risk factor? There are four risk factor. F as 4, you can remember like that. Females is firstborn, and the faulty interrupted position, that is the breech position. This is the breech position during the pregnancy that cause the developmental dysplasia of hip. Now we will see the pathology. The pathology, first we will see the bone into the bone. What is the pathology into the bone? The first bone is the head of femur, acetabulum, neck of femur, and the pelvis. Okay, the head of femur, the dislocated femoral head appears the normal at the first that appears the normal, but later flattened on the posterior and medial aspect. Okay, it appears conical in the presence of ileum. Okay, now the acetabulum, the shell of acetabulum with gap or groove on the posterior superior surface. The head of femur is contaminated with the depression above the acetabulum. Okay, as we see above the neck of femur. The neck of femur is anteverted or short. Okay, the pelvis is anteriorly tilted, smaller, lordotic, and they more vertical than the normal. Okay, the another pathology is related to the capsule. The capsule shows the hollow glass constriction. Here we can see the hollow glass constriction. This is the hollow glass constriction. One with the head of femur and the another with the acetabulum. Here we can see one of the with the head of femur and the another with the acetabulum. Okay, this constriction produced by the iliopsoas. Here we can see the iliopsoas tendon that by the produce the capsule, and the ligamentum teres passes through the constriction, which is the hypertrophied. Okay, the another pathology related to the group of muscle, that is the pelvifemoral group. Okay, the first one is the pelvifemoral group that includes the adductor, sartorius, gracilis, rectus femoris, hamstring, tensor fascial lata muscles. Okay, these are the muscles are shortened and they prevent the reduction of the head. Okay, this is the one of the cause that related to the pathology. Okay, the another is a pelvitrochanteric group. Okay, pelvitrochanteric groups that are including the muscles that are obturatus, quadratus femoris, and the iliopsoas. Okay, what are the difference into the that? These are enlarged and the psoas forms the reduction of the muscles. Okay, that also cause the DDH. Okay, now the gluteus muscle. The gluteus muscle shows the little organic change, but power is diminished. Now we will see the clinical features in infants. Okay, the gluteal and the thigh folds are symmetrical. Okay, and the perineum is widened. The adductor of the hips is decreased by the 50%, while the internal rotations movement is increased. Okay, the another clinic features that are the into the children and the adolescents also. Here the patient shows the wilding and sailor's gait. Okay, here we can see the gait. Okay, and there is an increased lumbar lordosis. Okay, the deformity is frequently encountered in the unilateral case, shortening in bilateral case. The lower limb are shorts, perineum is widened, and the buttocks are broad and flat. Okay, the femoral artery is prominently felt. Okay, the adductor is lateral rotation, adductor and the lateral rotation movements of the hips are decreased. Okay, the telescopy and the Trendelenburg test are positive. The most common seen clinical features into the adults, that is the DDH in adults shows all the features seen in the adolescents, and in addition the patient will have the features of secondary osteoarthritis of hip, mainly pain, stiffness, limb crepitus and restricted movement act. Okay, thanks for watching the video. Please share and subscribe. If you want to PDF, then link in description.